Good morning again, everybody. I'm very happy to be in Barbados, though not my body, but my soul, my spirit, my mind. As an islander myself, I do miss seeing people in person, but hopefully soon. It's been a pleasure to be working with Cancer Services this year, as I did before, last time in person. I have to thank Ms. Harris, who is the International Patient Concierge hand-holding organization that assists patients to access care in Florida, New York, or wherever the patients may wish to have care if that care is not available in their country. And this would be part of the group in the United States with the largest number of treatment centers located. Our goal is to make the treatment as convenient as possible and closer to home. We are a global company, and being more than 5,000 employees in 5 countries, we do have access as a group to the best and the latest technology, which is for the benefit of the patient. We don't expect patients themselves to understand the details of the technology, but to trust that whenever there is something that is declared as best practice by our peers internationally, that in fact we make that available to patients. So this is constantly changing, and I'm going to talk about something old and something new. At Cancer Services request, I am talking on melanoma, and it is the most dangerous skin cancer. And it is a cancer that is conventionally thought to just happen in fair skins, but it does happen in dark skins. My grandmother was darker than I was, and she died from a malignant melanoma. This is the skin. We have a superficial layer and then a deeper layer where all the blood vessels are. And then there's these darkened cells here that are called melanocytes, and they produce the pigment. So if you have a mole, then that mole is from the melanocytes, because that's what looks dark. What makes a mole and a melanoma a nasty cancer? Well, these cells can change and gain the ability to break into these little things here, pop into them, which is the blood vessel, and pop into these little things on a microscopic level, which is the lymphatics. And these cells show us certain features that tell us that they have that ability. And then we need to know that this patient's life is threatened, and we need to take it very seriously. So the first step, of course, is to know what it looks like, because everybody has moles. These are all melanomas, and you're going to notice certain features about them. This is a melanoma of the nail. It's called a subungual melanoma. And the melanomas can either be nodular or flat. One thing you notice is that it's very irregular. You also notice something called asymmetry. So this is what you, who are all interested in cancer, need to be able to see and pick up very easily in yourselves, your family, your friends, and say, that doesn't look good. What happens? The border is very irregular, and then there's asymmetry. One half doesn't look like the other half. Then the color, look at the color. It's not regular. Some places are pigmented. Some places appear this color, some this color. It's not uniform color. The borders are very, very ragged. And the other feature, which you can't see here, is that they grow pretty quickly. And that is called the ABC. Oh, I've lost my clicker. I'm sorry, give me 1 second. Can I say next slide and you'll move the slide for me, because my clicker just disappeared? Yes, great, thank you. So the important thing for our group here today to know is that the type that it is on the normal sun exposed, as we all know that the biggest risk factor for having melanoma is heavy sun exposure. And it's very common on the torso, the chest, the back, the limbs, and those are areas that might be sun exposed. But what about under the foot like this? Under the foot is not really sun exposed, and you have this nasty melanoma. In fact, my grandmother died from a melanoma that started under the foot. And it's important that I show you this today, because this is the type that is found in people with darker skins more commonly. So people with fair skins so that people in Australia, people in Florida, they tend to get on this area you can see. But these things are unfamiliar. In fact, the physician who was taking care of my grandmother in Trinidad kept calling this a fish eye until it had spread. So it wasn't really picked up because he didn't know what it was. So this is something to be aware of. Next slide. Next slide. Can we have the next slide? Okay, so just to remind you that you as a cancer advocate would know something that is one half doesn't match the other half. The border, AB, is for border, irregular. The color is variegated. It's not uniform, A, B, C. The diameter is a little bit bigger than about a pencil eraser. It's not a little tiny dot usually. And then E is evolving. It keeps changing. Next slide. Okay, so the only way to make a diagnosis is a biopsy. We can't just look at it and say it's a melanoma. We can't feel it. We can't say, well, my grandmother had one, so this is a melanoma. We need to take a piece off, and usually the surgeon or the dermatologist, and in our case in the Caribbean, the primary care physician often does this. They're very well trained, and they take a piece, and the pathologist looks at it. Next slide. And what he's going to look at is to see the depth of it, because the depth correlates with the stage. Stage tells us how it's going to behave and therefore how we're going to treat it. If it's very, very surface, that means it's very early. So most cases, we just need to remove it and no other treatment is needed. If it's very deep, then we're dealing with a different story. You have to check the lymph glands, and if it is positive, you have to scan the patient's body. If there's spots, then we treat it very differently. Next slide. So if it is just where it is and it's very, very shallow, very thin, a couple cells, then me? Can you hear me? Hello? Yeah, okay. So if it has spread, then there are 3 medications. Old classic chemotherapy, which is medication that just kills cells that are rapidly dividing. And that's why it has side effects like hair loss or sore mouth or bowel changes, because those cells are rapidly dividing. So it affects other things apart from the melanoma that is rapidly dividing. What is new is targeted therapy. And that is based on specific cancer cells, not the patient. The cancer cells has mutations, changes in the genes, which we now have the ability to detect and check for. So there are specific genes that we can check for. And if they have it, then we have drugs that target those genes and stop them from stimulating the cancer to grow, grow, grow. The very genes that make it cancerous, that make it grow, 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 and invade is the genes we can now target. And that's called targeted therapy. The third medication is something that you would have heard of. It's called immunotherapy. And we all have an immune system where our bodies can detect things that are bad and eat it up, gobble it up, basically. It's a complex system. And what we've now detected is we have been able over the past 2 decades to do research and find out why it is when we have cancer cells in the system, our own immune system isn't gobbling it up and getting rid of it for people who have cancer that's growing. And it's because the cancer has ways of tricking the immune system into thinking it's normal. And now we have drugs that can trick the immune system and trick the cancer cells to say, hey, this is not normal. And then it makes our own immune system gobble up. And that's called immunotherapy. And these are all medications, either pills or infusions. You do have very good medical oncologists in Barbados who are educated and trained and are aware of these medications. So if somebody has melanoma, these are things that they may be discussed. If it's spread, it's nowadays these things, when up to 10 years ago, I would say somebody with melanoma that spread to the brain, we would say, this patient doesn't have more than 18 months to live, because by 18 months, we know in the past, all these patients had died. Nowadays, we don't no longer say that, because with immunotherapy and targeted therapy, we have patients that have had cancer that's spread throughout the body that are living many, many, many years. So targeted therapy and immunotherapy has changed things. Next slide. In our field specifically, and what is unfortunately not available in the Caribbean right now, is a new thing that has changed the way we treat people with cancer that has spread or people with small primary cancers using a painless technique that is only developed because we have better imaging and we have better system that guides the therapy to go into just the cancer so that we're not hitting normal organs, and that's called stereotactic treatment. You may hear words like stereotactic body radiotherapy, stereotactic radiosurgery. You may hear gamma knife or cyber knife. They're all the same thing. Gamma knife and cyber knife has been around many years. I have patients from Barbados who come up to, I treat, who have tumors that's in the brain, small tumors for which gamma knife has been, or cyber knife has been used. What is new is that any linear accelerator that we have right now in all of our machines, we don't need a cyber knife or gamma knife. We can do this with the machines we have in our clinics because of improvements in those machines. And secondly, not only can we treat small brain tumors, we can hit tumors in most parts of the body. And I'm going to show you what I mean by that. Can you go to the next slide? Okay. What stereotactic is basically, this is a picture. This illustrates how many beams it might take coming in from how many directions to focus on one little pinpoint and get that dose. This is a very precise treatment. That's what stereotactic means. It's either 1 or 5 treatments. So it's done in 1 week. It's no longer like weeks and weeks of radiotherapy. And the reason we can do it in such big doses in a small number of treatments is that we're not hitting normal organs and therefore they're not getting damaged. We also treat primary lung cancer where the cancer itself has started, like primary lung and prostate, providing they're small. But most use right now that has started over the past 5 years and is now the new paradigm shift for people with a small amount of spread of their cancer, not widespread, is to treat cancer that has spread to the bone or the lung or the liver or lymph glands in the body or the brain. Next slide. So these are some examples of what I'm talking about. See, this patient, this is a slice of a CAT scan. If you imagine the patient is lying on the table, this is the back. This is one breast. This is one breast. You're looking at the patient from the foot of the table, and we're slicing through the patient like we slice a tomato or cucumber. So this is the blood vessels here. And this thing here is a cancer spot that has spread from a melanoma. And what we could not do in the past is give a super high dose of this that will completely destroy the cancer, because the way the beams used to hit other organs is it would damage things like the spinal cord or the ribs. And therefore, this patient is going to have much more damage that we can give. Nowadays, you see where that red volume is? We can get that entire dose to be concentrated right there. So we're actually not even hitting the rib, although it's so close to the rib. This is a patient with a spine spot. Again, in the old days, we can't hit the spinal cord. We now have the technique to paint the dose here. And if we are not hitting the spinal cord or the kidneys or the liver, then we can crank that dose really high, because the spine itself, the bone, takes a very high dose. And we can paint the dose on and get rid of it completely. And this patient can live for many, many years. This patient here had something called a metastasis to an adrenal gland. And again, we were able to destroy it and get rid of it. And this is a reproduction of a brain. It's the outer, the scan is showing up the bone itself, so the patient's eyes. And these are how many little spots that were in the brain that was completely ablated, and the patient went on to have many, many years. Next, of course, these patients will also be on immunotherapy and targeted therapy that is also helping. Next slide. This is a reproduction of one other technique where we had many, many little tiny, tiny, tiny beams coming in. So if this is 100 beams, imagine only 1/100th of the dose is going to here. This patient will have no side effects in the brain, no side effects on the skin or the skull, because if we look at the patient from the side, this is a young patient, as you could see. This is the skull. This is the patient's nose. The chin is here. This is the spine. So the patient's face is here. The back of the head is here. The back of the neck here. The purple is a normal brain stem. And look at where this tumor is. So this is one of the most horrible diseases to treat, because in the past, if this grows, it pushes the brain stem, the patient will either die or become permanently paralyzed. And then the brainstem does not take the kind of doses that we needed to destroy this tumor completely. So if we are treating with techniques that were available up to, say, 10 years ago, then this patient may have spillage of the dose here. We're no longer spilling the dose. We can confine it, and this patient was cured. Next slide. This is a patient with melanoma again. Even with these many spots, looking at the patient from the side, this is an MRI. That's why it looks a little bit different. This one is also close to where the brainstem is starting. And with this treatment, we have a 95% chance of getting rid of these tumor. Next slide, sorry. This is a patient with lung. And again, when we map out the tumor, looking at the patient from the side, so this is the back of the patient, this is the front chest. I'm looking at the patient from the side. We have to map out the heart. We have to map out the spinal cord here. We have to map out the aorta, which is a large blood vessel. And then we get the dose into the tumor here that confines. That red dose is not spilling on anything else. And we could crank that dose up again. 95% chance of getting rid of this tumor that is in this patient's lung. Next slide. All right, this is a very interesting slide. Probably one of the most exciting things in my field that we're doing now. This is a patient with a spine spot. This is the vertebra. So I'm slicing through the spine, and this structure here is the spinal cord. This is the big cable that brings all the messages from the brain down to the arms and legs. And in the old days, when radiation was like a brick, if you imagine a plank of wood coming through, how could you send a radiation beam like this and not hit the spinal cord? We can't curve a beam, but with computers and new technology and engineering, we can use very complex algorithms. The physician will map out this red target, and we get this green dose to wrap around the target, and it's curving beautifully around the spinal cord. This is an amazing achievement. If Marie Curie was alive now, she wouldn't believe this, because we can't bend a radiation beam. Next slide. So this is now a new paradigm. No longer are we seeing with patients who have small spots that have spread and they're well, otherwise they're not, obviously very, very, very sick. On the clinical trials that are now published and considered best practice, it's up to 5 spots, but we have trials doing more than 5 spots. The spots are completely obliterated. Many of these patients live much longer than without. In fact, when we did some clinical trials, those trials had to be closed early because the people who was getting stereotactic versus the normal chemotherapy and systemic therapy, they were living so much longer that we couldn't put those patients on the trials anymore. It was unethical. We had to stop the trial. So any cancer that has spread from cancer of the prostate, lung, breast, colon, melanoma, kidney cancer, basically almost any cancer that has, wherever it started, providing it's not, wrapping up the spinal cord or, wrapping up the optic nerve, a physician still has to decide carefully that if this is feasible, but we're doing it more and more every day. And this is we have a new, so I'm going to give you a new word. It's called oligometastatic. We had patients who the cancer didn't spread. So they have cancer that's controlled in a local area of the body. Then they have patients who are metastatic. They had cancer all over the body. And we always thought we either treat people who are metastatic, they're not curable, we're controlling it, or we treat people where the cancer hasn't spread for cure. In this case, we have a new group called oligometastatic. Oligo means a few. They have a few small spots, they have spread, but they are now considered potentially curable because of radiosurgery and radiotherapy. Also with the addition of, good imaging to be able to pick this up precisely, and the availability of good systemic therapy, the ones I mentioned to you, immunotherapy and targeted therapy. But in addition, when we give immuno and targeted therapy, those patients are living longer, and they live long enough to develop these little spots, which we now come and literally zap them with stereotactic. Next slide. We also treat primary cancers of the prostate, pancreas, certain brain tumors, and lung cancers using this next spot without having to have surgery. Next slide. So thank you so much, Cancer Service, for again giving me the opportunity. It's been a pleasure. When I spoke the last time many years ago, I still remember. I still have all my pearls that I was given. It was a pearl celebration. It was for breast cancer. And GenesisCare is available to you. Can you go back to my last slide, please? Can you go back to my last slide, please? Okay, yes. So my name is Dr. Ahamad, but I work with almost 1,000 doctors specializing in different things. And the patient who has in the past and continues to handhold and bring patients from Barbados who need their treatment is Miss Harris. And she has a concierge service that will arrange the hotel for the patient, pick the center that's closest to their relatives, if they have relatives, get whatever letters for the visa. I actually got a patient from Barbados about 2 months ago who didn't have a visa, and she called. She had an emergency. The neurosurgeon called Miss Harris on Friday evening, and the patient didn't have a visa and was in the clinic. I was in Miami by Sunday night and started her treatment by Monday evening because it was an emergency. So she's able to do that. I have an elderly couple from Barbados who came. It's probably about 10 years now. No, 8 years. And this was a really nice story because she tried to explain to them what we need, and she hadn't yet given them the hotel that they were going to, etc., and what time the car was picking them up. Hadn't told them to book their flights yet. She gets a car to pick the patients up at the airport. The patients went ahead themselves and turned up at the airport in Miami and called her and said, "We're here." And she said, "Wait, what do you mean you're here?" She said, "Well, okay, do you have lunch? Do you have a credit card?" They said, "No, we just have cash." She said, "Okay. Do you know where you're staying?" "No." She said, "Well, I don't have a driver." Okay. So she jumped in her car in Fort Lauderdale and drove them, picked them up, used her credit card, checked them into a hotel, took them for lunch, which really warmed my heart. And this is why I work very closely with her, because I can close my eyes and make promises that I know I'm not going to be let down. At the end of the day, patients need that coordination. They don't have this horrible thing where they have to get in to see a doctor and get an appointment. Our global clinical leader is a gentleman called Wally Curran, who's the head of radiation research for the United States. And he was the chairman at a very well recognized academic institution, now guiding our guidelines. And we focus on making patients' care accessible, whether it means reducing prices, whether it means making sure they're comfortable, whether it means we communicate with their doctors back home. So I, again, thank Jan and David and Cancer Services, and of course, tech support for being so patient with me. I really enjoyed it. I look forward to returning to Barbados in person. I'm from Trinidad originally.